it's very possible, even when a mother has adhered to her antenatal visits, for the unborn baby to develop some unwellness. And this is what we call fetal distress. After the last visit to Imara MedPlus Hospital in Embu, we received awesome comments about the discussion, postpartum hemorrhage. And once again, we are privileged to have Dr. Mokua.
Thank you very much
for
introducing me. Salama sana.
Thank you very much.
I hope your stay in Embu was welcomed.
Yeah, we were.
It was, yeah?
Yes.
Sawa. Thank you very much.
We are here to discuss fetal distress.
Yes.
But before this, please tell me, how are you doing here?
Basically, we are doing okay. But as we all know, we still have a responsibility to the people of Embu, and we are supposed to deliver services to them. And it's not only me alone. We have a team of doctors and specialists. So for the specialists, we have obstetrician, gynecologist, we have orthopedic surgeons on board, we have surgeons, we have physiotherapists, we have occupational therapists, we also have nutritionists on board. Last but not least, we have well-qualified nurses who work around, who also have a background of midwifery and who offer antenatal services to our clients.
Then Imara is big. You people, you're big.
We are trying.
Thank God.
Yeah.
You'll make it. So can we discuss fetal distress?
Yeah, it's okay. And thank you for giving me this opportunity once again to present fetal distress to the audience. So I'm going to be very brief and precise about fetal distress. So in layman's language, one can say fetal distress, this is when the unborn child is not well. Yeah, this is when the unborn child is not well.
Basically that.
Yeah, basically that. That is the layman's language or the layman's way of understanding. So, but medically one can say this is a condition which the unborn fetus in the mother's womb is not well. And we have several parameters which determines the wellness of the unborn child inside the uterus.
Please tell us about those parameters.
Yeah, so basically the parameters, the most important parameter is the fetal heart. And when I say the fetal heart is normally within a range. And the range is from 120 beats per minute to 160 beats per minute.
That is how the heart is beating.
So that is how the heart is beating per minute. Like an average physiological developed adult, you have a heart rate between 60 to around 80, an average of about 72. So if you have your heart beating within that range, now that's when we say you have a normal heart rate.
Okay.
But now for the fetus is slightly higher and rapid. So for that range of 120 beats per minute to 160 beats per minute. So anything less than 120, then we know there's compromise with the fetal heart. And anything above 160 beats per minute, then you also know there's something compromising the fetal heart. In the hospital setup, we have several gadgets which can assist us to pick the fetal hearts, and it also depends with the gestation age that one can pick the fetal heart.
Gestation is the age of the fetus when in the uterus.
Yeah, the age of the fetus when in the uterus. It's actually how the fetus is maturing in the uterus. So one of the gadgets is called a fetoscope. So I managed to carry one.
Thank you very much.
I managed to carry one. So now this is how it looks like. So it just looks like, somebody can even call it a vuvuzela. I know we have people who have imaginative minds.
It's true.
Yeah. So I can briefly describe it's funnel shaped, but this instrument is very vital in detection of fetal distress. So what it does, it picks the fetal heart. As you can see, its structure, it's wider on the part where it's going to come into contact with the mother's belly, and it's narrower to the part where it's going to come into contact with the examiner's ear. So this one is to facilitate transmission of vibration. Is more clearer in such a shape. Yeah. So it's basically placed on the mother's belly, and one place is ear or her ear while examining for the fetal hearts.
And you are able to pick the rate.
And you are able to pick the rate. So this instrument is basically used in the 3rd trimester. This is when you can correctly pick the rate, because for the 1st and 2nd trimester, remember you also have maternal structures, maternal arteries which have pulse rates, and the pulse rates correspond to the heartbeat of the mother.
So you can easily
so
confuse.
You can easily confuse
okay,
the two.
I
So
get it.
it's basically encouraged to be used in the third trimester. I also carried another instrument which is superior, which is a superior modality than the fetoscope. It's called a sonarcade. It uses the vibration method to pick, and it resembles an ultrasound. It has a probe. It resembles an ultrasound, though this machine is quite smaller. So it basically picks the fetal heart alone. So I also managed to carry one.
Thank you very much.
Okay. So this is just a protective casing of the machine, yeah? And this is how it looks like. So this is how the machine looks like. So as you can all see, it has a probe. This probe has the same function with what this part of the fetoscope
does.
This part of the fetoscope does per se. So one has to apply some gel because for you to transmit sound, it's better transmitted when you have a substance which is going to distribute the vibrations evenly. So once you've applied your gel, and like this one, you don't need to apply any gel. So once you've applied a gel on this on the belly of the mom, where you suspect you've located the fetal heart, then you can gently place your probe and you switch on the machine. While it's on, if you pick a heartbeat, it's going to fully elaborate the heartbeat. It's even going to give you the range of the heartbeat. If there's any irregularity of the heartbeat, it's going to show you because the range will be shifting. Maybe showing 120, and then within 3 seconds 160, and then within 5 seconds again 140. So those shifts are the one which one has to consider. Yeah. Then last but not least, Anne, we have a machine which is called a cardiotocograph.
A big name.
Yeah, it's a big name, a very big ambiguous name. But it has several functions. So for the cardiotocograph, what it does, it picks the fetal hearts, and it also picks the mother's uterine contraction. As the word suggests, cardiotocograph. So cardio is for the fetal heart. Toco means contraction of the uterus. So cardiotocograph. It can pick both the fetal hearts and it can also pick both the maternal contractions.
Thank you very much. I think this is awesome. We need to go for a break, but when we come back, we'll continue with our discussion. Thank you very much. Let's go for a break. Well done, viewers. Back to our discussion, still at Imara Med Plus in Embu. Daktari,
yes,
could you please tell us some of the predisposing factors to the unwellness of a baby when still in the uterus?
Oh, sawa. Thank you, Anne, for that opportunity. So even before I touch on the predisposing factors to fetal distress, I will want to just elaborate in a nutshell the factors which will contribute to the wellness of the fetus while in the uterus. So we have several factors which play a key role in the wellness of the fetus. So one of the factors is if the mom has any other predisposing condition. When I say if the mom has any other predisposing condition, you might find mothers who have other medical conditions which can influence the outcome of the fetus or the outcome of the baby. So such conditions such as diabetes, cardiac diseases, diseases of the kidney, chronic hypertension, among other conditions which also can be obtained when the mom is pregnant. Now conditions such as preeclampsia and eclampsia, as you'll see, they overlap with hypertension. So, and the list is endless. So such conditions can contribute to the wellness of the fetus.
Let me ask you one question. What about the habits of the mother? For example, smoking and drinking, and not water, drinking beer, alcohol.
It's very true. Very true.
Can it affect the baby's wellness?
Yeah, of course. We also have a big contributor to lifestyle way of living in terms of contribution to the wellness of the fetus. As you all know, cigarette smoking and alcohol is contraindicated and prohibited during pregnancy.
perfect word.
Yeah.
Indicated.
And prohibited.
Go.
Because it might affect the growth and development of the baby. And then we also know if somebody is alcoholic, the person might be malnourished and will not get the adequate nutrients to be supplied to the unborn fetus. Now, it's very important for one to adhere to a very healthy lifestyle so that to guarantee wellness of the unborn child. Yeah.
Are there other predisposing factors?
Yeah, we also have other predisposing factors. Yeah, as we had discussed earlier, we only dwelled on factors affecting the mother.
The mother, yeah.
But you can also know the fetus per se can also have factors affecting its own health inside the uterus. So the first one that I will start off with is if there's any element of genetic predisposition or genetically predisposed diseases, conditions such as syndromic conditions such as Down syndrome. We have the trisomy 21, and the list is endless. We also have some genetic predisposition to congenital anomalies, and we also have maybe drugs which now the mom use. Now this is about lifestyle.
Okay.
Drugs which the mom can use and can also affect now the well-being of the baby in terms of development. And then you also know that the baby is being maintained inside the uterus by a very vital organ called the placenta. Yeah, so from the placenta, this is where the baby gets nutrients, this is where the baby gets oxygen, and this is where the baby can exchange his metabolic waste and have the mother expel for him.
In Kikuyu, it is called elephant.
Oh, it's called elephant.
In
so
Kikuyu.
Because it's very big, it does a lot of function. Yeah?
Don't worry, but it's called elephant. In Kikuyu.
We'll have a lesson after this
We will
show.
do Kikuyu lessons.
So going back to the placenta, so anything which is going to cause placental insufficiency, anything which is going to make the placenta not deliver its functions well, it's going to compromise on the well-being of the fetus. Yeah. So we have conditions, maternal conditions and fetal conditions which can affect the placental integrity, and that one can affect the state of the fetus.
Thank you very much. Now let's have this scenario where a mother comes to hospital. She's come for her visits.
Yeah.
How will you tell that the baby is unwell, has fetal distress?
Has fetal distress. Yeah, that's a very good question, Anne. And I think now this is the take-home message for clinician. This is the take-home message for we can also say for the well-equipped traditional birth attendants, because we cannot deny that fact. We have deliveries done by traditional birth attendants.
Some of them are trained.
They are trained.
Yes.
So they should actually also be trained to this and to be acquainted to these signs and symptoms, of which they might even make a decision of not delivering the baby there and make a quick decision to transfer the mom to a well-equipped hospital. So one of the signs is reduced movements while the baby is still in the uterus. So as we all know, as the baby is developing, the mother is going to be feeling the fetal movements variably from time to time. The kicks. Yeah, some say amegonga huku sana, mwingine anasema leo sijamsikia akicheza. But at least once in a while, at least about 3 to 4 times in a day, the mom should be hearing the fetal movements. So when you get that the fetal movements are reduced, so this is one of the signs that maybe the condition of the kid inside is not okay, but it's not a guarantee, but it's very good for the mother to seek a medical opinion. So for the doctor to properly evaluate, do a clinical evaluation of the mom and the fetus, just to establish all the wellness of the kid. Yeah. Another thing is when the mom is almost to deliver, it's not expected for the mothers to drain liquor first, but you might find the mothers have drained the amniotic fluid, and the amniotic fluid is stained with the fecal component of the unborn child. That fecal component is normally called meconium. Meconium is the first fecal component that the unborn or the newly born kid normally passes. So that is normally a very key indicator of fetal distress. Yeah.
So the baby is supposed to pass this stool once it is born.
Once it's born.
If it happens before the baby is born, that's unawareness.
So that's normally a sign. Not 100% to guarantee it's a sign of unwellness, but it's more often than not a very important key indicator of unwellness of the sign. Because sometimes maternal contraction can also contribute to the kid passing the poop. But you might even find maybe the mother was fully dilated, and maybe this is when the liquor is changing color. So we wouldn't really term that as fetal distress, but because we know the delivery process is just about to go on. Yeah, so you can really consider, but it needs a well-trained and a skilled professional
to note this. Thank you very much, Daktari. Stay tuned, we'll be back.
Yeah.
Thank you very much for joining us once again, and if you've just joined us, we are discussing fetal distress at Imara Med Plus Embu. Daktari, please tell us about the predisposing factors.
Thank you, Anne. We have several predisposing factors, and predisposing factors, as I had explained much earlier, the predisposing factors will dwell on which aspect is being compromised. Remember, I told you we have maternal causes, we also have the fetal causes, and we also have the placental causes. So any cause which has any relation to the three components can actually become a potential cause of fetal distress. Now, what do I mean? An example, condition like anemia. This is a very prevalent condition in our community. We have people, because of cultural differences, mothers not taking enough feeds which are rich in iron and folic acid to try and build up blood, thus ending up with anemia. You also have mothers who culturally are not allowed to visit the antenatal clinics, so they are not well supplemented with the supplements to boost blood, so they also end up with anemia. So anemia in its own way is going to compromise on the oxygen delivery of the baby, and as a result you are going to end up with fetal distress. And then you also have placental causes, anything which is going to affect the placenta. Name it. It could be the pregnancy-induced hypertension. When I say pregnancy-induced hypertension, this is the likes of the preeclampsia, the likes of the eclampsia. This is going to affect the placental integrity. We also have multiple pregnancies. Multiple pregnancies, you'll find we have 2 or 3 fetuses depending on one placenta. So you might find one placenta, you might find one fetus developing much healthier than the other fetus because of now maybe the differences.
So in short, you're saying you can have twins sharing a placenta.
Sharing a placenta. It is very common, and it's one of the causes that can cause fetal distress in the compromised fetus. So multiple gestation per se is also a contributor. We also have conditions such as genetic conditions such as Down syndrome, such as the trisomy 21, which if it's in severe form, they are incompatible with life. We also have the Resa's incompatibility. When I say Resa's incompatibility, I simply mean the positives and the negatives that we normally have in our blood group.
And that's why it is important to do the
antenatal profile, which does not only has the blood group, but it also has the rhesus factor. So if you're a rhesus negative mother, maybe married to a rhesus positive father, and the chances of you getting a rhesus positive baby is there, and once you have a rhesus positive baby, the mother is going to produce antibodies against that rhesus factor, and that one poses a great risk to the baby. So probably the initial pregnancy might go without any complication, but the subsequent pregnancies might be fatal. You might even find your kid not making it to the term pregnancy.
That is big.
Yeah, that is very big. It's actually a topic on its own.
It's a topic
but
on
it's
its
a
own.
very good contributor and a good predisposing factor that one can put when you're discussing about the wellness of the fetus in utero.
Thank you
And
very
the list is endless, and anything which is affecting all the three components, has to be elaborated on well.
Let me ask you one question.
Yeah.
What about this instance where the baby goes beyond the expected date of delivery? If the mother is told you'll deliver on 10th October, but 20th the baby is still not
Or the baby is still
born.
not. Thank you, Anne. Thank you for also reminding me that point. This is what we call post-term delivery. So post-term, it's expected for term pregnancy to reach at the age of 40 weeks. But we consider it's post-term if the mom has completed more than 42 weeks. And what is greatly affected here is the placenta. The placenta becomes insufficient to deal with the demands of the baby because the placenta was only scheduled to maintain the pregnancy till term. But now, because we are post-term, the placenta is decreasing in size. It's also decreasing in terms of function, that it's delivery.
Thank you very much. Let's go back to our scenario.
Yeah.
This mother has come and you have already made your diagnosis that this is fetal distress.
Yeah.
What is this mother going to expect now from here?
Yeah.
How is she going to be managed?
So, as we all know, the main aim of treatment here is to have a well-delivered kid and also maintain the health of the mother. So we have to work as a team. We also have to work in precision so that at least we can save the life of the baby. So one of the things that one can do is to let your mom rest. And you let your mom rest into a comfortable couch and let her lie in the left lateral position.
Left
lateral position.
Any specific reason?
That is normally the recovery position for pregnant mothers. So when a mom who is pregnant lies on the left lateral position, it normally gets good relief because we need the oxygen to be delivered to the placenta, and you know the oxygen is coming from the maternal blood vessels and also from the maternal heart. So by the mom lying on the left lateral position, remember the uterus is very gravid and it's very big and it's compressing on the maternal organs and the maternal big vessels which supply blood to the heart. So once they lie on the left lateral position, this gives a relief to the maternal big blood vessels, and then we have good blood supply to the heart, and then now from the heart we'll have our placenta being supplied well with oxygenated blood, and it's a form of resuscitative measure to the kid as we now address on the definitive management.
A simple measure, but great.
A simple measure, but has great results. And now the other thing that one can do, you can also supplement oxygen because you know your unborn child is getting inadequate oxygen. So you can just place the mother on supplemental oxygen, and that one is also going to help. And also what we came to realize that is of very great help is by giving intravenous fluids. So by giving intravenous fluids, this one helps nourish the mother, and it also helps the baby who's not born to expel the unnecessary metabolites inside. And it's also very it's also very helpful for both the mom and the unborn child. But last but not least, what we need to do, we need to weigh the scenario. It's like weighing risks and benefits. So what risks do we have by letting the baby to remain inside and continue with the normal labor? And what benefits do we have if we plan for an early delivery of the baby? So this should be done by a clinician, and the clinician should be well trained and should have calculated his or her odds properly. So the main treatment, because we want good outcome for the baby, when we feel we have fetal compromise in terms of the well-being, I think the best method of delivery here will be via cesarean section, and this one should be well explained to the mom. Let the mom understand what the child is going through inside the womb, and why the cesarean section is very necessary. It should also be provided by an informed consent, so that at least she understands the risks and the benefits of what is just about to be done, and also to be explained to on the outcome of the delivery.
Thank you very much. Yeah. Seems that the management of fetal distress can only be done in a hospital setup.
Yeah, it's basically in a hospital setup, to be done by well-trained and well-equipped health personnel.
Just before we wind up, please just tell us in one sentence some of the complications.
Some of the complications
of fetal distress.
Okay, so some of the complications, let me just mention about two, but I'll mention the major complications. So one of the complications is when you get a baby not getting enough oxygen while still in the uterus, you might get his or her brain is becoming insulted. So they end up getting something in medical terms we call birth asphyxia. So birth asphyxia is when a child gets inadequate oxygen supply to the brain. And this one has detrimental effects later on in life. You can have a child getting delayed developmental milestones. You can also have a child ending up with mental retardation. You can also have a child ending up with a condition called cerebral palsy. So all these are related. And if it can be prevented, I think we can greatly reduce the incidences of these conditions.
If it is prevented, the mother gets a golden minute.
Yeah, the mother gets a golden minute.
Thank you very much. Dr. We've got no words to thank you. Thank you very much for being with us. Until we meet again, viewer, this is Golden Minute Show. I remain your host. Keep with us. Bye. I knew. So thank you very much, Daktari.
Thank you.
It's always a pleasure having you in our show.
Thank you.
And for you viewers, thank you very much for keeping with us. I believe you've learnt a lot. And as you could have picked all along, antenatal visits are very, very important. From us here in Golden Minute Show, I remain your host, Anne B. Till we meet again, bye.